All right. Good morning, everybody. Welcome to Coplow Rounds this morning. I'm Dr. JB Miller. I'm one of the staff pathologists here, and I'm going to get us started. First couple cases. There we go. Okay. Uh, First up, we have the left eye from a 2-year-old male neutered Rottweiler dog, um, who comes with the history of on ophthalmic exam. They noted that the eye was ophthalmic, that there was diffuse corneal edema. The iris and pupil, there's some slight abnormality to its shape, so some slight dyschorrhea. They noticed diffuse hyphema, and they couldn't really see much past that, but they did say that historically there was maybe some slight microphakia or small lens and an early cataract noted. Um, and they also said that historically that there was complete retinal detachment / disinsertion, and that they were not able to see any retinal tissue evident on their previous exams. And the optic nerve had decreased pallor. For the right eye that we did not receive, they did note there was also some dyschorrhea and subtle microphakia as well. So they enucleated this eye, which was submitted to us, wanting to rule out some congenital things with this globe. So here is our gross hemisection of our formalin fixed eye. It's a little bit tilted than we maybe normally see. That's because we wanted to take a look at this back of the globe here. But before we get there, we've got cornea at the top. It is cloudy. Here is our lens right here. You can see that there's some red material in the anterior chamber, so consistent with the hyphema. And then strikingly, the optic nerve head should be somewhere about here, but it's not really visible. It was noted to be maybe like a faint indentation in the region. There we go, maybe about here. We can see that the rest of the optic nerve is still coming off the back of the globe. And then the other thing that we can see here is that we can see our choroid pretty well, this pigmented layer here, but it's really hard to make out the retina and where the retina might be. So let's take a look histologically here. All right. So kind of keeping our same orientation here. We've got cornea at the top. We can see the hemorrhage in the anterior chamber here, maybe a little bit in the posterior chamber. Our iris leaflets here should be coming out this way, but they're kind of plastered onto the globe. I will say that this globe, as we noted, they noted clinically was ophthalmic, so it was a little bit big to fit in our regular mega size cassettes. So we did what we call a Swiss roll technique, where we make a sharp incision into the posterior sclera here and kind of roll the tissue on itself. So it kind of looks like a Swiss roll, like little Debbie cake kind of thing. It just helps save us on space and block storage and such and costs. So here is our optic nerve, and we don't really have optic nerve head. And the other thing that we know here on the back of the lens here, there's this little light pink tissue, and we'll take a closer look at that. All right. So starting at the front of the eye, we've got cornea here. And starting here at our iridocorneal angle, here is Descemet's membrane, and it kind of ends here. It kind of runs into an iris-like tissue. You don't really see a good trabecular meshwork or ciliary cleft. There's maybe some also posterior displacement of the aqueous venous plexus. And we can see some blunting of our iris stroma here, and our muscle here is being curled externally. So we've got some ectropy on uvea, some iris blunting, and we've got a nice little cellular membrane that covers the front of the iris and kind of attaches to Descemet's membrane. Some of it looks like a little attenuated. kind of spindle or cells with some vascularization, some pigment. There might even be a little bit of membrane formation. So maybe this is some desmetization of the iris where the corneal endothelium kind of crawls along the iris surface, produces basement membrane. Let's look at the other side real quick. We can see a similar change. I can get it in focus. There we go. So we've got the iris is broadly adhered here. Again, no trabecular meshwork or ciliary cleft. Some posterior displacement of our venous structures here. And a little bit of hemorrhage in the anterior chamber. Again, kind of this nice membrane that kind of goes over there. So there's definitely membrane formation and some abnormalities here that might suggest that there's a little bit of some anterior segment dysgenesis occurring in this angles. And then if we look at the lens, our lens capsule here anteriorly is thick, as it should be. And if we follow the lens capsule around the posterior portion of the lens, it should be nice and thin, which it kind of starts out that way. But we do notice is that there's posterior migration of the lens epithelium. They really shouldn't come past the equator there too far. And then we can see some degeneration in our lens fibers. So we've got some liquefaction. We've got some rounding up here where they've got some more ganglion globules. We've got a couple that have maintained a little bit of their nuclei, so some bladder cells as well. As we keep following the lens capsule, it gets really thick back here. It's almost to the thickness of the anterior lens capsule, which is interesting. Something that we kind of see in congenital cataracts. And then, as we pointed out from low power, there's this pink tissue that was kind of along the back of the lens. There's lots of hemorrhage here and some hemosiderin-laden macrophages. And this tissue here is the artist formerly known as retina. So there is retinal tissue here, though it's not normal at all. There's no layering. There's no ganglion cells, inner or outer nuclear layers. And then the other big thing to notice here is that there's no blood vessels in the retina. So this is an avascular retina. And then heading back, if I can find here you go. Didn't really get, there wasn't really much of an optic nerve head to sample. And then the rest of the optic nerve is kind of atrophied and gliotic. We got a little bit more prominent collagen beams here, and a little bit of gliosis as well. Gets atrophied. So with the lack of the optic nerve head grossly and difficulty finding histologically, and in conjunction with that avascular retina, we've got optic nerve like hyperplasia, and with complete retinal detachment or possibly even non-attachment. It's hard to tell at this point if the retina was ever attached during the development of this eye. So it's all part of a congenital abnormality for this dog. In addition to the lens findings, probably congenital cataract, and then some malformations in the iridocorneal angle for anterior segment dysgenesis. The avascular retina was probably really wanted to have a blood supply and was probably producing VEGF, which likely helped contribute to the membrane formation as well, and maybe this hyphema, although we can't really rule out maybe blunt trauma or trauma to a blind eye in this case. Either way, there's no indication that the remaining eye would be at risk for congenital abnormalities, although they did note some dyschorrhea in the other eye. So just some interesting congenital abnormalities in this eye.
Did you say optic nerve hypertrophy or
Hypoplasia. Yes. So, yep, like I said, just kind of some multiple congenital abnormalities in this eye, some of them highlighted a little bit in bold for this case.
Just so go back to the gross imaging. Because
Yes.
this is a case where it's very important for you to read the notes when you're sectioning the eye, or ideally, the person that's either have a picture like that or the person that's reading the slides of section the eye, because you can see here the optic nerve is not very obvious, right? And you can get a section like we had on the last one histologically,
Mhm.
and you might think that you're just not sectioning right through the optic nerve, and then you try deeper sections and the optic nerve disappeared, and you might think with yourself, well, maybe we cut through the optic nerve. So in order for you to get a definitive diagnosis, identifying that there's no obvious optic nerve while you're sectioning, or that the optic nerve is very tiny, like here, it's very important, if not almost necessary for a definitive diagnosis. The retinal detachment or the retinal non-attachment here and the avascularity of it is important too, because it adds to the suspicion. But having that, um, it's um, it's important to know. So there might be a little pit over there. See that? Right. Yeah, that might be all there is.
Mhm.
And Maria is asking how old was the patient?
Uh,
Yeah. I will spend a little bit more time blending the videos together and do some you know, a real YouTuber.
In the history, it
Mhm.
said that they knew that there was retinal disinsertion.
Yeah.
Yes.
So at some point they were able to see that.
So they also said no retinal tissue evident,
Yeah, that was
which
confusing.
Were they talking about the same eye? Because I know that they were talking about two eyes in the history too.
uh, for the left eye that we received, it says retina, history of complete retinal detachment slash disinsertion, parentheses, no retinal tissue evident.
Oh.
If it's not there, it can't be
Very strange
inserted.
to
Yeah,
think
so
it
they're
would be a metric.
probably differentials. They're giving two differentials, either
Possibly, yeah.
one or the other, something like that. Good.
Excellent.
Okay.
Okay,
Mhm.
awesome. All right, next up, again. All right, is a 10-year-old Maine Coon mixed female spayed kitty cat. This is a representative photo of what we received. So this kitty cat comes with a history of presenting with bilateral chorioretinitis with complete bullous retinal detachment in the left eye, which is the eye that we received. Presentation, there was mild anterior uveitis in both eyes. And during the course of the treatment of the chorioretinitis, the right eye progressed to focal bullous retinal detachment as well. So they did a lot of testing in this animal. They reported a normal blood pressure, unremarkable abdominal and thoracic imaging, CBC, Chem, UA, FELV, FIV, and the feline coronavirus were all negative. They did extensive infectious disease testing, including Cryptococcus coccidioides, blastomycosis, histoplasma aspergillus, anaplasma, babesia, apicomplexa, cytoxone, Ehrlichia, mycoplasma, and rickettsia, which were all negative. The patient was positive for IgG positive for toxoplasmosis and positive for Bartonella on PCR. So initially, the patient was treated with clindamycin, doxycycline, and pradoxicin, which did not stop the progression of the chorioretinitis. They tried some prednisolone. They started symptomatically, and after about a month or they started the prednisolone after about a month of the antibiotic therapy, which worsened the retinal detachment in the right eye. So after 2 months of extensive testing and treatment, they elected to enucleate this left eye in hopes to sort of figure out what was going on and help with treatment of the remaining eye because it was still visual in the remaining eye. The eye that they submitted to us was blind. So, like I said, this is just a representative photo from what we had, and most of the front of the eye was pretty quiet. And there was this thick tan mottled appearance to the choroid, We kind of saw a loss of distinction with like the tapetum. The retina was detached and kind of thick. And they also noted that there was some subretinal white stuff in our case, which you might imagine. See little white dots here in there. So let's take a look. Right. All right. So, as I said, front of the eye, not too exciting. The party is here in the back. We've got our retinal detachment here. It's a little bit torn as well. And we can see that there is a lot of increased cellularity blueness here that should not be there. So let's go take a look at that stuff closer. All right. Here's a nice pretty cat angle. Nice and normal. Again, lens was fairly normal. There was maybe some posterior migration of the lens epithelium, so some early cataract formation. Our retina is detached, and it's also pretty atrophied and gliotic. It's got these clear spaces with some eosinophilic material in it, so there's some edema accumulation, which is retinoschisis, which can be a consequence of long-term retinal detachment. And then if we go to the choroid, there's a little bit of lymphoplasmacytic inflammation, kind of peripherally. And as we move more centrally, it gets busier. And if we get closer, the cellular infiltrate here is a mix of cells. So we've got these larger polygonal cells with these big nuclei. Sometimes you can see a prominent nucleolus. So we've got some macrophages in here. We've got these segmented nuclei here in these cells. So we've got neutrophils as well, which are, those two are the predominant inflammatory cell in here. So we've got a pyogranulomatous choroiditis with some lymphocytes and plasma cells kind of scattered around in here as well. So this is very suspicious for an infectious etiology, despite all the infectious negative testing. So put a GMS on. Right. Oh, it's because I'm too close. That's why. That's weird. All right, there's our detached retina. Gonna head back. And go to this handy little blue dot. Yes, I wish all of our slides came with magic blue dots that told us where the lesion was and what the important thing was. So this is a GMS stain, so it's a silver stain. You can see some kind of irregular, kind of black-brown staining here. So we've got some melanin granules, but what we're really focusing on here are these discrete, round 3 to 5 micron yeast structures. Zoom in a little bit here. Ooh, enhance. So they're kind of scattered around. Move a little bit. You can see them here, there. And
Oh, is that a
nope, hold on. I can't.
narrow base bloody?
Wait. Here we go. Aha. So
One, two.
two.
Oh my God, you're right.
Little
Favorite.
So
Write that down.
yeah, so these lovely little organisms here, the size and this narrow base budding here is consistent with histoplasma species, despite their histoplasma. I think they say histoplasma antibody was negative, possibly because there weren't too many in here, but anything more than 1 or 0, I think, is too many fungal yeast to have in your eye. Basically, this probably represents a systemic manifestation of systemic disease, especially with the other eye also already having chorioretinitis as well.
Trudy's asking geographically where.
Geographically where this is from. Florida.
Right.
Mhm.
I have a theory about these. So histoplasma has a very, well, all the systemic fungi in the US have a very specific distribution. Well, minus Cryptococcus, which is everywhere in the world. But histoplasma, blastomyces, kind of, Ohio and Mississippi River basins. And my theory about all these, not all, but we had a handful of cases, cats from Florida. And my theory is that these are retired people that moved from Ohio to Florida. And bring the cats to them. They bring their histoplasmosis to Florida.
I believe that theory. We had several histoplasma cases in New Jersey and it's not very common there. And like those are two of the dogs that I saw were born and raised in North New Jersey. There was no travel history, but their people traveled.
All right.
So
Glad to get some confirmation of
my anecdotal.
my anecdotal.
Oh, hi.
Huge chunk of my population when I worked in Ohio went down to Florida every year. So
Break this up.
Very good.
Yes.
And also another point about the negative testing.
Mhm.
I've looked into almost all of our cases back for a project, and a lot of them were negative, and some of it has to do with the phase of distribution of the disease. Because I think if it's mainly ocular, there might not be a lot of circulating antigens because of how the eye is sort of segregated, even though, the ocular blood barrier in a case like that is probably disrupted by all the inflammation, but it might not be reached enough circulating antigens to cause a positive test. And there's a lot of cross-reactivity with other fungal infections. So don't be
Yes.
surprised also if you get a blastomyces positive in histoplasma case, vice versa, things like that.
Regarding the urine antigen tests, I feel like this is worth stating. I knew about cross-reactivity between blastomycosis and histoplasmosis via urine antigen testing, but only found out yesterday, I will admit, that actually for urine antigen testing, it's the same antigen between blastomyces and histoplasma. So like there is total cross-reactivity for the urine antigen test. Anyway, thought that was
Good,
worth saying.
thanks. I didn't know it was that bad.
I know. Yeah, me
I
neither.
knew about
For
cross-reactivity.
version of histoplasmosis, whether it's dog or cat, obviously you saw the organisms in the back of the eye. If we're assuming like primary ocular infection, is that the common distribution in the cases you've seen or no?
I think it's almost, so the question was, does the distribution suggest a primary versus systemic disease of systemic infection? I think we assume that all of our cases are systemic.
Okay.
And the classic presentation, it's very similar to all the systemic fungal diseases like a chororetinitis, plus or minus endophthalmitis, which suggests something systemic. You see something in the back of the eye in a choroid, you tend to think about a systemic disease. That doesn't mean it can't happen. You can't have a dog or a cat that it's unlucky enough to have a penetrating trauma contaminated with histoplasma, but the vast majority of our cases have this systemic pattern of infection. Do you guys agree with that?
That makes sense. It was just a very boring like full workup for a cat that might have systemic.
And that's not uncommon. We see that often where there's no history of systemic disease or,
Obvious.
they are obvious, or they would tell us all about the histoplasmosis that they had 6 months ago after we sent a report and asked, oh yeah, I had histoplasmosis. Forgot to tell you guys.
I wonder too, our sample pool in Coplow is pretty biased towards ophthalmologists who've seen patients for eye issues. So maybe the spotty systemic history is somewhat part of that sampling bias.
Right.
An oculocentric worldview, if you will.
That makes sense. Cool.
Sweet. All right.
Oh.
Yeah. Very cute cat. So I have my next two cases are clinical images. They're both very striking. I want to thank the clinician for both of these images. So our first one is from an 11-year-old male castrated domestic short hair. I'd say we can see kind of the main presenting lesion in this photo. But the history we received was this cat had mild crested discharge from the left eye. They're unable to visualize the globe. Periorbital palpation revealed a firm diffuse swelling in comparison to the contralateral orbit, and there's a firm pink mass that was kind of effacing the ventral palpebra, as we can see here. The clinician did do an impression smear of the mass, I assume from the surface, which was non-diagnostic, as we might imagine. It was mostly just red blood cells and neutrophils. And then they did a couple of punch biopsies from within the mass, including the surface epithelium. And they did an impression smear from those, and it revealed epithelial cells. And those are the main findings. And as I mentioned, they did punch biopsies. That's what we received. We just received a few little cylindrical tissues that we bisected and put on the slide. So check those. So this deviates a little bit from what we usually see in that we don't have the whole globe. Oh. Even doing subgross is going to be kind of overkill, but here are our tissues. Very cute. Actually, I'm going to show this one instead. We have a little duplicate section. We have my nice helpful dots. I know, this one came from dots too. Our histo team is so nice to us. All right, so let's check these out. This section over here. Ooh. One day I'll focus. Here we go. Okay. So here are little punch biopsies. We can imagine like maybe these two are the ones that were bisected, like these are from the same biopsy. You can see there is a little bit of normal surface epithelium. So this is epidermis. I'll go closer to show there are some little hair follicles too. In other areas, we don't really have that surface epithelium anymore. So if we just received this, we'd be hard pressed to say where we are around the eye. It just looks like this really dense collagenous stroma, and there's these weird cells intervening between it. So look closer, focus, there we go. Let's quickly show. So here is our epidermis. We have a cute little hair shaft here. In some other areas, we can see there's some hair shafts also in the deeper stroma, but really the majority of the dermis here has just been effaced by this neoplastic population. And even from this low power, I can tell you that these are epithelial cells, mainly because of the pattern they're making and kind of their morphology. So in a lot of areas, we have like these lobules of cells. Maybe sometimes they're making these almost tubular structures. Some places they're doing more of these trabeculae. So these are all very consistent with an epithelial neoplastic pattern. In addition to that, we also have this abundant stroma in between these neoplastic cells. Going closer to that. It kind of has this very loose, kind of light appearance. It's very cellular, has these pretty active looking spindle-shaped cells that are interspersed with that stroma. So this is a desmoplastic stroma or a scirrhous response. And we see this most commonly with malignant epithelial neoplasms. In this case, it doesn't really tell us anything else besides that, but it can be a helpful indicator in some cases, especially if we have, say, like foci of epithelial dysplasia or a squamous cell carcinoma in situ, or we're trying to see if there's stromal invasion. This is something that we start to see if there are places of stromal invasion. So it can help cue us off that we should be looking for that. Anyways, let's actually look at these cells now. Vamped on a little too much about the stroma. So in a lot of areas, these just look like your kind of basic malignant epithelial cells. So they have a good amount of cytoplasm, these round oval nuclei. I'll even go in closer. Finely stippled chromatin, and then 1, 2, I think there's a few places where there are 3 nucleoli. They're pretty prominent, magenta. Already we can see that there's a pretty robust mitotic rate. So even in this field, we have 1, 2, 3 mitotic figures. And they're pretty bizarre looking. Like, I don't know what phase this is. It doesn't know what it wants to be. It just looks like a firework at this point. It's just a bunch of chromatin. So as we kind of move around, as I mentioned, there are some areas where it's doing kind of these tubular patterns. Otherwise, kind of just looks like your malignant epithelial neoplasm, which in a lot of these cases, when we have these punch biopsies, it's hard to say where the cell of origin is. There's a lot of epithelial structures in this region. It could be surface epithelium, so like what we see at the squamous cell carcinoma. In this case, we don't have areas of squamous differentiation or keratinization, so we'd be hard-pressed to call this a squamous cell carcinoma. There is glandular tissue in the region associated with the follicles. In the third eyelid gland, there's lacrimal gland. This area is close to the nasal cavity. So there's a lot of places that these epithelial cells could be coming from. So in a lot of cases, we kind of just hand this back and say, this is a carcinoma. You're going to have to use your clinical impression to tell where exactly it's originating from. In this particular case, we do have some other helpful features that can maybe tell us what we're looking at. Focus. Ooh. So in this little kind of tubule-like structure, it's a little disorganized. These epithelial cells also have these. So this is apical cilia. It's maybe a little hard to make out, but we can kind of see they're kind of like wicking together here. This one, they're kind of straight across. So these are all little cilia. And they're scattered here and there amongst this population. So this is not something that we commonly see with, say, a squamous cell carcinoma or with a lot of our kind of glandular tissues from like the third eyelid gland, the lacrimal gland. Instead, this is a common feature of respiratory epithelium. There are reproductive structures that can also have ciliate epithelium, but this is an 11-year-old castrated cat, so seems less likely. So in this case, this kind of helps narrow down our differential list a little bit more. So we do see ciliated epithelium within the nasal cavity. So could this be a nasal carcinoma that has kind of bust through the bone and is now kind of emerging out of the orbit on the left side? It could also be from elsewhere in the respiratory tract. So say a pulmonary carcinoma that's metastasized to this region. Does seem like a weird location for it to pick, but feline pulmonary carcinomas do like to go all over the place. So like the toes, they'll go to bone. They do like to metastasize pretty far if they're going to metastasize. And those are kind of the main features of this. With these punch biopsies, we can't really say much else about. Obviously, margins are dirty. They just kind of want to know who this is before they go in and do a more definitive therapy, probably.
So nasal lacrimal duct is also has some ciliated parts to it, but I'm not aware of any neoplasm
That'd be interesting.
that has been described to be originating from the ducts. So just as another potential ciliated epithelium around that area. But
Man, that'd be pretty crazy.
yeah, it would be crazy.
Yeah. All right. So let me back to this. So they ended up saying, yeah, carcinoma with differentiation of presumed respiratory epithelial origin. So it could be nasal carcinoma with kind of this orbital, periorbital extension. It could be metastatic from elsewhere. Could be a nasal lacrimal duct carcinoma, which would be kind of interesting. And ultimately, again, just have to kind of throw this back to the clinician and say, yeah, consider imaging to see if there is nasal involvement. Definitely do a chest radiograph to see if there is a primary pulmonary carcinoma. And this one we don't have any follow-up on, so I can't say much else about this case, but just a very nice carcinoma with nice features.
So Dr. LeBlanc here is saying, oh, this is my case.
Oh,
Unfortunately, the owner elected euthanasia and discomfort with the primary care veterinarian.
yeah.
Financial constraints prevented them from further workup or pursuing treatment. Try to contact them and let us know if the owner elected necropsy, but haven't
Okay.
had a call back. Thanks for sharing. Yeah, thank you for sharing
Yeah, thank you for the follow-up. That's very helpful.
and for the pictures.
Yeah, really thank you for the images. There's a very striking gross photo. Oh, sorry to hear that. All right. Yeah, sorry for the jump scare.
Should have saved those for Halloween.
Like I said, I have two very striking clinical images. So again, thank you to both of the clinicians here. So our next case is a 5.5-year-old female spayed boxer. Again, kind of the presenting complaint is a little bit obvious. So the history we got was this dog has a 1-month history of anterior uveitis, which eventually led to glaucoma. The eyes were painful. There was buphthalmos, as we can see here in this image. They did perform blood work, CBC Chem and 4DX, as well as checks X-rays were unremarkable. And this dog was otherwise healthy on physical exam. So, as I mentioned, don't have gross photos of this one. We do have these clinical images showing marked bilateral buphthalmos. Cornea is also quite cloudy and opaque. We have, a pretty prominent injection here on the sclera. Otherwise, just taking a look at the face, the rest of this face looks pretty all right. We can come back to this image later, maybe. But grossly, when we were looking at both of these eyes, we received both of them. They were both buphthalmic, and we noted that the uveal tract was thick with a bunch of exclamation points. We had noted that the iris was mottled tan and brown. The remainder of the uveal tract was dark brown and seemed appropriately pigmented. Those are kind of the main points. We had mentioned that both of them looked grossly symmetric as well, which may or may not be relevant.
And having lived with at least 3 boxers throughout my life, I bet this dog walked in all happy and
So happy,
bouncing.
I'm sure.
Unaware of what was happening.
I do love boxers, so this dog is very cute.
But that hurts my.
Mhm.
It's pretty close.
I bet she feels so much better though
Oh yeah.
with those eyes out. Okay, which eye do I want? Let's do the left eye. So I will show the left eye. I can pop the other eye on briefly, but I will say they both look the exact same. So, oh yes, that's what I'm doing. Every time my brain goes blank when I'm trying to do a suckers. Okay. So this one didn't quite fit on the slide very well. So we have the cornea up top. I'll show you as we move back, if you follow the sclera, there's this little discontinuity. So this is a jelly roll piece where we just kind of snip the sclera to get it to fit into the cassette. These eyes were quite large. We had to do it for both of them. Okay, so cornea up top here, there is something going on in the stroma here. It's a little busier. We can see some areas of red, so probably some vascularization of the stroma. You can see it over here as well. As we move back, there's a little bit of material in the anterior chamber. Kind of the main lesion that our eye should be drawn to is our uveal tract. So here's one of our iris leaflets. Here's the other, and they are thick with a bunch of exclamation points. There is some sort of cellular infiltrate within the iris stroma. It's in the ciliary body. As we move back, here's our choroid. It's also within our choroid and maybe sneaking into the sclera a little bit as well. Just a little bit more pallor in the sclera. There's a little bit of hemorrhage too in the posterior chamber. This is probably ventral, so maybe it's just kind of settled into the chamber. Lens isn't particularly exciting in this younger dog. And then our retina is detached. So our cornea is on the right side, moving left, that's going to be more posterior. And we do have a corneal ulcer. So here is maybe your conjunctival epithelium, corneal epithelium, and then it becomes discontinuous. So we just have this exposed stroma. There is a little epithelial flap adjacent to the ulcer. So this is an indolent ulcer in a boxer. So this boxer is doing all the proper things. It's a pretty extensive ulcer too. You pick up our epithelium over here, perhaps. And indeed, there is some vascularization. Let's just show that really quick. Dancing around the main lesions here, but here we are. So there are some vessels in the stroma. There's a lot of this kind of more disorganized fibrous connective tissue. So we do have some kind of fibroplasia as well. As we get closer, there's maybe some desiccation where the exposed stroma's hypereosinophilic, has a little bit less cellularity to it as well.
Did you call it a sequestrum?
I don't think we did. I think we just said desiccation.
Mm-hmm.
The elusive canine sequestrum.
Right.
All right, let's move back. There should be a drainage angle here, or iridocorneal angle should be present here. At this point, it has been more or less just effaced by the cellular infiltrate. Perhaps there is some sort of kind of membrane that's also formed. Here's the termination of Descemet's membrane. So there's kind of something that's heading from the iris over the termination of Descemet's membrane. So we have a lot of good reasons for glaucoma. I don't think aqueous is going to get past this area at this point. All right, let's actually look at our iris stroma. So we have the cellular infiltrate, and it's a pretty heterogeneous population of cells. So this is an inflammatory infiltrate. We do kind of in the background have some plasma cells. You can see the perinuclear clear zone. There are some lymphocytes as well. These guys are kind of the more condensed round nuclei. But the majority of these cells are macrophages. So we have these round cells. They have these really open nuclei. They always look like potatoes to me. That's how I've always described them. As we look at this population, we can see a good chunk of these do have some degree of melanin pigment within their cytoplasm. Usually it's kind of just these coarse granules that are kind of scattered and peppered throughout the cytoplasm. Sometimes they have more within their cytoplasm. And as we move around, you can also see there's quite a bit of necrosis too. So this is iris still technically, and it's just all necrotic. It's just replaced with this eosinophilic material, and there's kind of extracellular melanin pigment. Ton of ciliary body necrosis. As we move back to other more intact areas of ciliary body, it's still just more macrophages mostly, again, just with this kind of scattered melanin pigment within their cytoplasm. Moving back into her choroid, showing everything. Again, kind of similar population of cells. So this is a pan-uveitis, and with the very prominent histiocyte population, the fact that they are oftentimes laden with melanin granules in their cytoplasm, and the fact that this is a bilateral presentation is most consistent with uveodermatologic syndrome or VKH-like syndrome. I can quickly, while we're on low power, let's see. Just show the right eye, just to show that it is a strikingly similar distribution. So here's our iris leaflet in the other eye. So typically these are quite bilaterally symmetric. They present at a very similar time point. So again, those are all very supportive lesions in this case. And I'll just zoom in here. So the fact, I can go back to the clinical image, but you'll note that there was no dermal lesions that we saw on the face of this dog. I think classically, when we think this entity, we think about the fact that there should also be cutaneous lesions. But the majority of cases we get don't have a history of cutaneous lesions, or they occur after the eye goes. So oftentimes the eye will be kind of the first presenting sign. So the fact that this dog doesn't have cutaneous lesions does not rule out uveodermatologic syndrome as a differential for this case. And in this case, it seems extremely supportive. Other things, this dog is a boxer. Typically, uveodermatologic syndrome, we've classically learned, occurs in Arctic breeds. However, in our database, we see it in all sorts of different breeds. So the fact that this dog is a boxer also doesn't rule this out. And the fact that there's no other inciting cause of this inflammation, the fact that it's so uveocentric, we really don't have inflammation elsewhere in this eye. So like retina looks great. Maybe it sneaks into the sclera here and there, but really is just centered on the uveal tract. So that is kind of the primary diagnosis in this particular case.
Yeah, just remember that, it is an immune-mediated or an autoimmune disease against antigens or, in the melanin itself. We don't know specifically what it is. So if you remember that, you see how it makes sense that the inflammation would track all the pigmented areas in the eye and spare the non-pigmented areas. I mean, for a random inflammatory reaction that we see in the eye, there's no reason why you have so much inflammation in the uvea and nothing free floating around in the chambers, or no inflammation even spilling over the retina, which is right next to that super affected choroid. So those are very useful features to look for. And Kelsey's going to show that's very pretty. Look at that tip right there, and the third one to the left. 1, 2, 3.
Third one to the left one. Like this
Yeah.
guy right here.
Yeah, see how?
Yeah.
So we have a pigmented and a non-pigmented epithelium on the ciliary body. And you see how the pigmented epithelium on that tip is gone, but the non-pigmented epithelium is still there. It goes to the same idea of targeting melanin-laden cells.
So here's our non-pigmented right here.
And also
here's the
something that
pigmented.
it is impressive, Kelsey mentioned that, but when we receive both eyes, the similarities or, the symmetry between the lesions is uncanny. It's just like how if in one eye, the anterior, in one case, the anterior uvea will be more affected, the other, on the other eye will be the same. If it's diffusely affected, it will be the same. Sometimes even the secondary lesions, like this one has pretty similar corneal lesions too.
Yeah, it does.
And we do have a question here about, can
Yeah.
you please elaborate on indolent ulcers in boxers?
I don't know how much more I can say. I feel like they're just more common in boxers.
Yeah.
I'm not sure if that's just due to their anatomy, perhaps.
Yeah, they were called boxer ulcers back in
Yeah.
the day. So there's a high prevalence of indolent ulcerations in boxers. I don't know if Alvin Bentley's around here, but he's a specialist in there. But yeah, we see them more often, and that's the classic presentation there, non-attachment of the epithelium with a flap of free epithelium and loss of epithelial polarity.
It's also worth noting that people will call those SCEDs, which I believe stands for spontaneous chronic corneal epithelial defects. There we go.
Nice. I would not have taken that on.
Yeah, and they asked, does that include bugs, boxes? Yeah, I mean, we see indolent ulcers in all sorts of dogs.
We do.
Or and horses sometimes. So it's not exclusive to boxers. We see that as a secondary change in a lot of our cases because we don't get eyes enucleated because of that, but we do get Sometimes corneal biopsies, but most often they're like that, a secondary change that we see. So no, I wouldn't be surprised in seeing an indolent ulcer in any breed of dog.
Yeah. As I said, I don't know if I've had a disproportionate number of boxers with indolent ulcers, but you're right, it could be sampling bias.
Right.
How often are you nucleating eye for an indolent ulcer?
Exactly.
So
Very cool.
that's a good question. Guys. Again, Sherry's feeling much, much better, or she is. Oh yeah, I should share my diagnosis. Here it is. So yeah, I cut out a lot of the diagnoses, but here's our main one. So we have a bilateral panuveitis, most consistent with canine uveodermatologic syndrome or VKHX syndrome. All right, now I'll pass it over to Dr. Clemens.
All right. We'll see if we can get both of these cases in. It could happen. I believe. All right. I know, I almost feel like I should have switched the order of these last two, but regardless.
Can do whatever you want, can go
But then it'll be spoilers for this one.
super fast.
Okay, ready?
Sure.
Everybody close your eyes. Close your eyes. All right,
There you go.
we'll start with this one. Open your eyes again if you close them. All right. So, we're gonna start with this one, an 8-year-old spayed female beagle mix. So they say the right eye has diffuse consolidating hyphema, mildly improved with oral topical prednisolone and atropine, but secondary glaucoma and blindness developed. They also say possible white tan mass posterior to iris, very difficult to see due to hyphema. However, it was an extremely good eye for a bad eye from the clinician in this case. There was indeed, on hemisected view, a white tan mass in the ciliary body area. This eye that we are looking at now is not our specific case. We didn't have a gross photo for our case, but this is kind of what our case may have looked like. We said in this eye that there was a lot of blood in it, the vitreous was liquefied, and actually we had a hard time seeing the mass, mostly obscured by hemorrhage in our gross view. But we have it in histologic section. So maybe this is what it could have looked like, but probably in the actual case I'm showing, it would have been covered in blood. So here in the ciliary body, you can see the iris leaflet here. So we're in the ciliary body, we've got this white tan mass. As we cut through this case, you may have experienced some grittiness against the blade, maybe. This specific case also does have a retinal detachment. And then there's lots of blood inside the intraocular chambers, probably some cloudiness and cataract in the lens too. All right, F11? No, escape. Wait, what? Yes, escape. And then F11. Okay, right. There's a button that switches between anyway, I don't know technology. Okay. And here is our eye. So similar to the representative gross photo in our actual eye here, we have this little bump of a mass in the ciliary body, which is looking really pink, weirdly. So we'll take a look at that in a second. The irises are kind of nabinified. That's a very scientific term, but we've got a pretty severe ectropion, which is causing the iris leaflets to look pretty stubby. We've definitely got lots of hemorrhage inside our intraocular chambers. Maybe a partial retinal detachment, but that's not going to be our focus. We're going to go in on this mass in particular. All right, our cornea is now rotated to the right, and we have our optic nerve back here on our left, heading over to this mass. There are some appreciative noises coming from the audience. This mass is actually mostly comprised of coalescing beams of woven bone. So that's what we're looking at here. This is bone, straight up bone. And we've got it here on the surface of the ciliary body. You can see kind of like bits of the ciliary body epithelium, like still extant, but like this bone is invading into the ciliary body stroma. And it's kind of all in here in the ciliary body stroma. Little like surviving beams of the ciliary body's smooth muscle between here and existing melanocytes, and then just beams of bone.
Oh, differentiated.
Yeah, it's pretty well differentiated, which is interesting. You can see it coming up underneath the peripheral retina, right here at oriciliaris retinae, maybe invading the retina. I can't exactly tell if it's just under it or in the retina. Regardless, it's there. And it's also into this peripheral choroid here. And then we go over here, something that's kind of a little scary. Here we go. Also, I don't know if it was appreciative noises on that, but reactionary noises. So yeah, so we have these two thin-walled vessels here in the ciliary body, and inside them it essentially just looks like there's osteoid. There's not really like cells per se here, but osteoid shouldn't be in vessels, and so it looks very suspicious, at least, that the neoplasm in this case is in vessel lumens. So far we haven't really seen the cells that are causing this so much, but as we look along the ciliary body surface, kind of bridging the gap to the equatorial lens, we're getting a lot more purple in these areas. And what I'm actually going to do is migrate across the way over here. And we do have a good amount of purple lining the equatorial lens on this side as well. So they're getting kind of carpety. They're extending in strands through the vitreous.
Probably over the zonules there.
Yeah, they would probably use the zonules like a garden trellis. A very unhappy type of flower or ivy, perhaps. Anyway, we're going too far with the analogy. Here are our neoplastic cells. They are indeed neoplastic. So these are spindled, kind of rounded polygonal cells in some cases. They have eccentric nuclei often, which is kind of a feature of neoplastic osteoblasts in some cases. There is a decent mitotic rate. Here's a binucleate cell. That's kind of cute. But of course, I'm not going to pick up on mitotic figures quickly as we look around. But there's a few mitotic figures here and there. So these are neoplastic cells. They are producing bone and osteoid, and they have the appearance of kind of osteoblast-looking guys. So this is most consistent with osteosarcoma inside the eye. This is an extraskeletal osteosarcoma. And the question in a case like this is whether this is a primary neoplasm that arose in the eye. We do have a very small cohort of cases that were suspected primary, excuse me, let me get that back in focus, suspected primary osteosarcomas in the eye of dogs, mostly just based on not having a history of osteosarcoma elsewhere in the body. So we're kind of reliant on history in this case. Which means that it's kind of difficult. Sorry?
The breed, I'm sorry.
Oh, good question. The breed is a beagle mix.
Beagle, no.
It's unclear. Beagle mixed with what is the question maybe, but just beagle mix is what we got. There are a population of pluripotent cells kind of in the area of the ciliary body, which may theoretically be the source of a primary extraskeletal osteosarcoma in the eye.
We see chondrosarcomas between cats, right?
And chondrosarcomas, yeah. These are rare tumors, though, and ultimately the other differential in this case is this osteosarcoma that metastasized to the eye, and definitely the goal clinically will be to make sure not to miss that. So this patient would need a workup for potential primary sites of osteosarcoma or other metastases or things like that. And only if, a really exhaustive workup was done, not finding osteosarcoma anywhere else, could you maybe conclude that this could be primary extraskeletal osteosarcoma in the eye. We have like 20, I think Dr. T just looked it up. I think it was like 20 cases that were suspected primary osteosarcomas in the eye. And it was like 60 something osteosarcomas that were suspected to be metastatic. But I'm not sure. Don't quote me on those numbers. It's not many, is the point. That's it.
Any other areas of intravascular invasion, like the choroid away from the main mass?
Nah, it was just those two vessels that looked suspicious.
Those would be things to look for to help support the metastatic hypothesis. If you had multiple vascular areas or multiple multifocal areas of tumor throughout the choroid or throughout the uvea, more carpeting effect sort of multifocally, and the presence of intravascular component of the neoplasm also multifocally.
Yeah, which this case has carpeting and vascular invasion, so that's kind of two things that are worrisome, at least for metastasis. So, and I mean, regardless if it was a primary and probably invading vessels, you'd want to stage the patient anyway, whether it's coming or going, essentially. Staging is indicated. Yeah, very unusual. We don't see it that often. But I mean, we have seen it. I was excited about this, and Dr. D showed it to me, and I shamelessly stole it. Anyway. Do we have time for the other one? We have like 4 minutes. Do we want to try?
Yeah.
Okay. All right. Close your eyes again. Close your eyes again. Here we go. Meh. All right. Here we go. We're back. Okay. Open your eyes if you close them.
Oh, yeah. Little mag.
That's right. The highlights. This is a 3-year-old spayed female domestic short hair cat with a really cute name that I can't share with you. Just imagine a really cute name. So let's see, the right eye had no menace response, no dazzle reflex, static large area of anterior synechia from 3 to 5 o'clock with a fibrovascular membrane, dense vascularization present on this membrane towards the anterior lens capsule. They use the term Busaka nodules, which I don't see that often, which are usually corresponding to follicular development, like lymphocytic follicles in the iris, but they saw them laterally and altered iris color. Let's see, resorbed hypermature cataract, limited views of the fundus with vitreous stranding, and they can't see the optic nerve, but retinal degeneration is highly suspected, presumably because the cat is blind. So we have this site here, which is their site of anterior synechia, and the lens is kind of shifted in the pupil to one side. You can maybe see some of that like weird iris color change or maybe thickening. And on the hemisected view here again is that lens that is shifted to one side. We've got this synechia here sort of anterior and also to the lens. We have presumably a detached retina and some weird strands coming through the vitreous and connecting with the back of the eye. So when you have areas like this where the eye is kind of a little bit maybe wrinkled in on itself, you might have seen tight adherence of the muscle to a site like this. And you have this like white tan tissue that's lining the surface of the eye and like kind of spreading through. The suspicion here might be a rupture site. Okay. Highlights. Got 2 minutes. Here we go. We're going to start with the deepest section because we have 2 minutes. Ready, go.
Condenser.
Wait, condenser, and I totally was not doing the subgross right. Okay, so here's our anterior segment. You can see this area where the iris is all curled up on itself and fused in this fibrovascular tissue, both to the cornea and to the lens. The lens is indeed super resorbed. There's pretty much just like some fragments of fibers left as a nucleus, and the rest of the cortex is gone. We have this cute little fibrous nubbin off the back of the lens, which is sort of like thinking about extending towards the back of the eye. This is our deepest section, and we still didn't quite get what I would bet is a defect through the back of the eye, but it's thinking about being one with that band of fibrous tissue running from lens to the back of the eye here. We've got this really sad detached retina with a tear at its periphery on this end. Yeah. It's better demonstrated in other sections, which we may or may not have time to look at. But you can see that the Descemet's membrane is actually discontinuous here. So we've got a peripheral break in Descemet's membrane. There's fibrous to fibrovascular tissue bridging that gap and fusing the iris to that site. Peripheral breaks in Descemet's membrane are pretty common with blunt ocular trauma. Essentially, the force of the blunt trauma extends out in that direction. So we've got this cute little break in the anterior lens capsule at that level and a little bit of regrowth. We've got, if we head to where our fibers are left, the remaining lens fibers are lined by macrophages, including these really massive multinucleate giant cell macrophages. I know, they're so adorable. They're like the little engine that could, yeah. Like, I'm gonna hug this whole thing. Eventually, I'll wrap around the whole thing. Here's another one, really cute. So these macrophages lining the exposed lens fibers is also an indication of true in vivo lens capsule rupture, although in this deeper section we didn't need them because there are actually the sites of rupture. In particular, back here, we have this really huge rupture site in the back of the lens, and then that little fibrous nubbin is bridging that. You can see that it's kind of thinking about heading back here to where there's this site of wrinkling in the sclera. The choroid starts to get a little bit indistinct, although it's not obviously discontinuous here, with fibrous tissue lining its surface between the choroid and the neurosensory retina. And then there's also fibrous tissue just outside the globe. This is almost certainly a section really, really close, but not quite through a break in the posterior globe. So we have a posterior globe rupture site, which could have been from blunt trauma or could have been penetrating. Sometimes penetrating traumas create those little fibrous bands sort of following the path of penetration. But that is sort of possibilities. We can still see that fibrous membrane lining the epichoroidal surface, even away from the site of presumed defect. And again, that detached atrophied retina. We've got some retinoschisis here, even with some separation of the layers by clear space. And then it's a little bit fragmenty at this depth, but we've got this rounded up, atrophied end of the retina, which is consistent with an in vivo retinal tear. This isn't an artifactual discontinuity. The retina actually tore in the patient's eye in vivo. So, a bunch of trauma-related stuff. Long story short, briefly, I'll grab... It's fine. We're good. This is an even better tear, level of the tear. And then up here, this is an even better view of peripheral rupture of Descemet's membrane with fibrous tissue bridging the gap. All right, now I'm done. And angle recession, exactly. All right, so just a bunch of stuff that indicates trauma. Maybe blunt trauma, maybe a combo of blunt and penetrating, and that's about it.
All right, thanks everyone. See you guys in 2 weeks.
Yeah, great. Any of us with
Yes.
yellow or red things infected?
Wait, that's not what I wanted to do. Oh, no. Okay.
Oh, you're good.